I'm very grateful that I'm here today. Thank you very much for inviting me. And we're going to talk about an incident reporting form that we've produced for primary care. But I want to take it a bit wider than that, really, because I want to talk about patient safety generally, because it's something that I'm very passionate about. I know Sabina is, and I'm sure many of you are. This is sort of my old stumping ground, really. I did my training as a general practitioner in Sussex. I now live in Hampshire, but this is where I did my house jobs and various other bits and bobs. And it was working in a district general hospital sort of that way about 25 years ago that I realised that what a terrible doctor I was and how dangerous I am. And I thought I better not tell anyone about that because I was quite frightened and a bit depressed, really, because there I was, golden boy, parents very proud. I'd been to one of the best medical schools in the country, and I came out and I realised I started hurting people. And the first time you realise that, that's quite upsetting, really, and quite scary. And there weren't lots of other people sitting in the coffee room saying, I'm really hurting people, I'm making lots of mistakes, how about you? It was kind of a culture of, I won't tell if you don't tell. And I was working in a special care baby unit about, well, I won't say how many miles, but, tens of miles north of here. And I had a registrar who was the only registrar we had, who worked alternate nights. The consultants both lived about 25 miles away and would go home at 5 o'clock. And within about 10 minutes of taking up this SHO job, I was in charge of special care and the ward. And I knew nothing about babies, and I didn't know a lot more about children. And it suddenly realised I wish I'd turned up some lectures in paediatrics when I was at medical school. And it was all quite scary. And then one night in the middle of the night, we had a very premature baby born. And the registrar was on the ward and came rushing down and asked me to draw up some theophylline, which, for those of you who aren't clinicians, is a very powerful drug for babies for their lungs when they're not breathing very well. And so I drew up the theophylline. And as I was about to hand this to the registrar that he'd asked me to do, I was aware that I wasn't sure whether the syringe was full of theophylline or full of saline, or whether I diluted it correctly or quite what was going on. But I was aware that if we injected this very small baby with this very large syringe of stuff and it was neat theophylline, the baby would die. And thankfully I had the courage to say that we better stop, and we did, and we drew up some new stuff and we carried on, and I was a bit sort of chastised, and we never spoke about it. And I sort of felt at that time that the solution was for me to learn a bit more about theophylline, learn a bit more about paediatrics, work a bit harder, try and be a good guy, and it will all go away. And through my medical career, that's the way it's carried on. I've sort of felt that actually, when I don't diagnose the cancer, if I learn a bit more about cancer, it'll be fine. If I don't know enough about diabetes, if I learn a bit more about diabetes, it'll be fine. And I've had the privilege since then of being involved with patient safety and realising very much it's not just about the individual and how much we know. Actually, I know enough about diabetes, I know enough about pancreatic cancer to spot it, I know enough about sepsis, I know enough about lots of these diseases. What I need to think is actually I'm part of a system. And actually, clinicians, particularly in primary care, are not making full use of the fact they're working within the system. So actually working with our ambulance colleagues, working with our practice nursing colleagues, and working with our administrative colleagues, and also working with our secondary care colleagues, and looking at when things go wrong and really investigating them. And part of that is because we fear that actually if we say that actually something's gone wrong, we're saying actually I'm not a very good doctor. And actually that's not true. What we're saying is actually something's gone wrong. You wouldn't expect an airline to not ask their pilots what's gone wrong. You wouldn't expect other industries, police and so forth, not to look at what's gone on. We're a safety critical industry, and we need to look at what's gone wrong. When Don Berwick, who was the head of the IHI, Institute of Healthcare Improvement in Boston, was asked to come to the UK and look at the fallout from Mid Staffordshire, from the Keynote trusts, and what's happened in the UK, and England particularly, around patient safety, he produced this report back in 2013, A Promise to Learn, a Commitment to Act, and really was sort of saying, actually the biggest thing that can happen out of all this is learning. Where we're falling over is we're not learning. We're failing to learn when things go wrong. And I think most general practitioners, and I'm going to hone it down to talk a little bit about general practitioners, when you say to them, actually, don't you find that prescription that was lost for Mrs. Jones at the front desk last week, doesn't that happen to you every day? They go, yeah, it happens every day. Well, what about the fact your patient couldn't get an appointment? Yeah, that happens every day. Yeah, the patient couldn't get an appointment. The same things, the home visits that get missed, the ambulances that don't turn up at the right time, they're all happening. But we're not really got an effective system for making them learn. So Don spoke about the most important single change in the NHS would be to create a learning system. So I was asked to take on this role of head of patient safety, and one of the prime functions there was to increase the level of reporting, because what we're finding is that within general practice, the way we report safety incidents, and certainly my experience over the last 15 years or so, would be that we report things that go wrong through a significant event analysis within the surgery. And those should be reported up nationally through CCGs, through PCTs previously. But I would suggest they're not reported that well. The National Reporting and Learning System is a fantastic, almost unique opportunity within this country to gain all the learning from patient safety incidents. And those of you who work in secondary care, those who work in community care, mental health services, will be very familiar, I'm sure, with your serious incidents and incidents being reported through that structure up to commissioners, on up to the National Reporting and Learning System, when we create national learning. And we're seeing great things happening through that. That we would find things, for instance, like there's lots of instances of children swallowing watch batteries and having deaths because of that. Those incidents get reported on a national framework. People think, actually, there's lots of these coming in. Let's send out patient safety alerts so they don't happen again. And what we're seeing is that thousands upon thousands of incidents are being put into the national database, month on month. And actually, we're looking at the causes of serious harms and deaths in healthcare. Now, we know that serious harm happens to about 1 in 10 people who come into contact with secondary care worldwide. So it's really important that we learn from those incidents. So when I was handed this sort of opportunity, should we call it, to actually try and improve incident reporting in primary care, we pulled the data on what was happening on incident reporting in primary care. And what we were seeing is that actually the whole thing peaked out in terms of reporting in primary care in about 2009, 2010, and we were having the grand total of about 8,500 reports of patient safety incidents. Now, hopefully for some of you, you'll be starting to think 8,500, gosh, that's quite a lot, but it doesn't sound very many, considering that when my own general practice had 25,000 patients registered there, that was just one practice in Hampshire. Actually, 8,500 incidents, when we're talking about harm being very common, is not a lot. And what we are finding is that most of these incidents would be reported through local reporting and management systems. So most of them were coming through CCGs, PCTs, actually things they were reporting. And when you break those down, lots of them are secondary care telling us that things have gone wrong. Ambulance trusts telling us that actually we got to this patient too late because. And they're about primary care setting, but they're not being reported by primary care. And when you're actually looking at the numbers that are reported by primary care, they're incredibly low. So why is that? And should it be more? So when we look at the numbers of incidents in primary care, we know that in the UK and England, there's somewhere in the order of 360 million general practice consultations per year. And the best evidence we have, which is not fantastic, but worldwide evidence looking at primary care, is that about 1 in 100 of those contacts causes the patient harm. And by harm, I mean things I wouldn't want to happen to me. Definitions of harm abroad, and we're going to talk about that today, I'm sure. But about 1 in 100 contacts with primary care cause harm. So the simple bit of maths I've always done is, well, that's about 3.6 million incidents of harm. And we were getting at a peak about 8,000 reports. So something isn't working. I think there's something about an understanding of what harm is. I was talking in Portsmouth a couple of weeks ago, talking to a load of GPs and practice managers there, and we got into quite a debate about harm in primary care. I was making the point that if I give someone a diuretic and their sodium drops and they fall over and bang their head or they break their hip, I've harmed them. And there was a lot of uncomfortable shuffling and looking at the floor, and quite a vociferous argument about people saying, no, that's not harm. you haven't harmed that patient by giving them a diuretic. So I think there is an anxiety that harm is inevitable. And for lots of people, if we start talking about things we do to patients causing them harm, they're very uncomfortable with that. And I think that discomfort comes from the fact that they feel there's an attribution of blame in that. If you're doing something good for someone and you cause them harm, then how can you be held to account for harm that arises? And I think we need to do without blame. We need to move blame away. If you're doing something that's normal practice and it causes someone harm, it causes harm. Shout it from the rooftops, because we might be able to find a better way. It doesn't mean you're at fault. Jim Reinertson, who's one of the leading researchers into sort of quality and safety in healthcare, talks about the fact that the thing that we're motivated by is the care we give to the individual patient in front of us. We're not very good at seeing ourselves as part of a system. We're trained in that way. You know, I'm trained to look after you. If you come to me with a problem, I will stay late. You ask my wife, I will stay late making sure I've checked your blood results and I've made sure you got the prescription. I'll even, drop it round to your house on the way home. That makes me willing to take responsibility for you and the care I give you. But it also makes me willing to accept that I'm at fault if something goes wrong, and feel that very personally. And it makes me also willing to accept the fact that if it goes wrong and you're looking after the patient, it's your fault. And so we have a cultural thing within the way we're trained and the way we train as healthcare professionals that makes it hard for us to see ourselves as part of a system. So if I go back to my incident in the special care baby unit years ago, actually I've learned over the years that I was part of a system. I was part of a system where very junior SHOs were put in charge of special care baby units. Not very sensible. I was put in charge of a system where special care baby units were in small district general hospitals. Not a very good system, where there weren't enough registrars, there weren't enough junior staff, where actually we weren't very trained, where actually we didn't have systems for protecting drugs, where there were same looking vials with different things in. And those are systemic failings. I was the last link in the chain, but it wasn't necessarily my fault. We need to look at that. So this system whereby we're supposed to gain nationally from what's gone on, learn what's gone on in terms of patient safety incidents, and actually report that back to the professions as to this is the big stuff that's going on you need to know about, is actually really very, very difficult in primary care, because we're not getting a lot of patient safety incidents, and so we're not able to tell people what the big harms are. So Sabina and I were handed that hospital pass by Mike Durkin, the head of patient safety, to say, Martin, can you make everyone report their patient safety incidents? Perhaps you could send them an email to remind them that there's a national reporting and learning system, and that will help. So we asked people, when you're not reporting patient safety incidents, what's that about? I've also had the privilege of travelling the country over the last few years talking about patient safety before I was in this role with the National NHS Institute and NHS IQ. And one of the things I found is when you talk about the National Reporting and Learning System to general practitioners, nobody has heard of it. Not a few. Nobody has heard of it, okay? So the National Reporting and Learning System is not something that's in the remit of GPs. It's a bit like talking to GPs about sequins. They all blank over because they don't know what you're talking about. And I don't mean to insult GPs, I am one, but actually we need to make sure that people are aware of these things. So people weren't aware of the National Reporting and Learning System. The reality of the National Reporting and Learning System form is it was something that was designed way back when they were inventing, software. And it's a bit like filling in your tax form. It's about 40 yards long, it's not very exciting. If you don't know the answer to one question, it won't let you fill in the next box. You can't move on. So really unfriendly form. It's really designed for things like if something goes wrong on the heart-lung bypass machine at Papworth. It's not designed for when I've lost a prescription at the front desk in my surgery. So it's really designed at a sort of deep investigation, root cause analysis level. And it would take you about a week to fill it in. Well, I know as a GP I'm not going to sit and fill a form in that's going to take a week to fill in because it's not practical in the time we've got. People are really worried about blame. Really worried that if you send something out there into the ether that says, I've done something wrong, actually they're going to come and close you down, you're going to get struck off, the GMC are going to get involved. And actually, a lot of people are saying, well, actually, we send these forms in, and that's all we ever hear of it. Nothing ever comes back. So it was those kinds of things that we needed to address in trying to move that. So we needed to get something that made people aware of the National Reporting and Learning System. Actually, we need to make it really speedy and really quick to fill in, because most of the harms we're seeing in primary care are low harm, no harm. They are things that actually didn't cause people harm. They're not the serious harms and deaths, although we do see serious harms and deaths. The majority of harms we're seeing are very low harm. Now that's really important still, because 90% of the care we give is in primary care in the NHS, and the burden of harm to individuals is probably the same as all the bad stuff that happens where people get, their lungs punctured, aortas rupture and so forth. But we need to do something about the cultural, about the fear of blame. So we needed to create a system that's going to change that, and we need to do something that's going to feed back quickly. So I'll now invite Sabina up on the stage to talk about what we did.
Okay, so armed with the feedback that we received from GPs, and lots of GPs and practice staff were very vocal, we set out to redevelop the GPE form, that's the portal to report into the NRLS. And what we looked to do was to eradicate as many of the barriers to reporting as possible. We worked with colleagues at Imperial College to undertake a heuristic analysis of the old GPE form. And when we started looking at it, we realized why people weren't reporting. It was a form made up of 24 questions over 4 screens. And if you didn't know the answer to one of the questions, you couldn't keep going. You had to know all the answers to submit a form to the NRLS. So we quickly realized that we wouldn't use it to report, so I'm sure others wouldn't and don't. When we worked with Imperial, they undertook a heuristic analysis, and we compared our form to accepted principles. So, for example, if you were to use a form on Amazon, what would be good practice there? So just because we're the NHS, we don't have to have a really boring form for colleagues to complete. We reduced the data set hugely from 24 questions to 11 very quick completion questions. We also change the form so that you have a number of drop-down options, and within those drop-down options, the answers that are most likely to be answered from general practice were right at the top. So a GP or a practice nurse wouldn't have to spend ages sifting through 20 options to find the most appropriate answer. We also included some radio buttons which were pre-filled. So, for example, where did the incident occur? We pre-filled those, so again, to speed up the completion of that form. Martin mentioned earlier that the fear of blame is a huge thing that we need to address. And what we developed was that GPs and practice staff could actually report into the NRLS without identifying their practice. So at a national level, when we're using this data to look for themes and trends, the specific location of that practice is important, but not very important when we're looking for emerging themes and trends. So we left it optional for completion of the form, so you can complete the form without completing details of who you are in the practice. In addition to making improvements to the user interface of the form, we added some additional benefits as well. So if a reporter includes their email address when they're submitting a report to the NRLS, they receive a bounce back email which is immediate. And within that email, they'll receive a summary, a feedback of reporting. So that will tell you how many reports have we received into the NRLS, what types of incidents have been reported, and any other issues that we want to highlight from a patient safety perspective. They will also receive a significant event audit form that the practice can complete to support them within their practice for learning, but also can be used for CPD, appraisal, and also revalidation. In addition to that, the practice can save to their local drive a copy of the form. So again, that can be used for learning, but it can also be used very importantly as evidence of patient safety activity. So for example, if you're being inspected by say the CQC, you can use that as your evidence of patient safety activity. We also developed a quick access icon. So this icon can be very simply dragged and dropped to your desktop, and then the next time you want to access the GPE form, all the reporter has to do is a single click, and that takes you directly to the GPE form. We were also very mindful of the fact that a number of CCGs across the country have their own reporting systems. So the system was designed to complement local reporting systems. So if a GP or a member of practice staff reports an incident to the NRLS and chooses to share that with the CCG receives a real-time email to say, there's a report waiting for you on the NRLS for you to view. So that actually supports CCG's activities around patient safety as well. Likewise, if a report is submitted to a local reporting system, CCGs can also upload that onto NRLS. So we've got a two-way communication. At the end of February this year, we launched the GPE form as part of activity which was steered by the NHS England Primary Care Patient Safety Expert Group. We also launched some patient safety and general practice web pages as well to support general practice colleagues, as well as some web videos, some articles via the CQC. We also worked with some key stakeholders, so the RCGP, CQC, Health Education England, to raise awareness of this new form. But it was very much a very soft launch, so I know that there's lots of work around awareness that we still have to do, and we rely on CCG colleagues to support us with that. I've got some very, very preliminary data from the GP reports to share with you. So we can't really make any firm conclusions based on these because they're from a very short period of time. But I thought it'd be quite interesting to share those with you. But before I do go on to the numbers, I wanted to share some actual reports with you because the numbers sometimes take away from the human cost associated with incidents. And this is one that struck me. So a patient who was a type 1 diabetic attended A&E after a hypo and their insulin was stopped. The practice wasn't informed and no follow-up was put in place. The patient was discharged, became hyperglycemic and acidotic. The patient was readmitted back into hospital when a GP realised what had happened, and then the patient died 8 days later. So we don't really know if this patient is a child, a mum, a granddad, but this kind of shows where the reasons why we need to look at incidents. And although many of the incidents from primary care are the no harm, low harm, there is still a proportion that are severe harm. We've also received some really good reports showing self-reflection from GP practice colleagues. So for example, this one here where a GP prescribed some steroid eye drops based on information provided by a patient. When the patient went back to see his ophthalmologist, was diagnosed with raised intraocular pressure as a result of the steroid eye drops. And so again, it shows lots of self-reflection from the GP here. I'm not going to read this one because it's very long, but I just want to show you that we've received some really good detailed reports as well, which helps our activity. But we've also received some that are very, very brief. So muscle pain on statin, patient prescribed haloperidol. So we know we've got lots of work to do around raising the quality of the reports that we received. But at the moment, we're just very grateful for any reports that we're receiving into the system. So I've got some numbers for you. So as Martin said, earlier on the year, we were tasked with raising the number of reports into the NRLS, and we set ourselves a target of making a step change to reporting. So what we did was we looked at the numbers reported from from the launch of the GPE form in February to August 2015, and we compared that to the same period last year. So it's very encouraging to see that the early data shows a significant rise in reporting. We also look to see what the reporting has been from all routes available to general practice to report via, so the GPE form and also local reporting management systems. And it's good to see that we've seen increases there as well. Then we look to see what proportion were actually reporting anonymously. So you remember we said that there's lots of fear of blame, and in order to ease that, we allowed reporters to report anonymously into the NRLS. but only 7% of reports actually took up the option to report anonymously. So 93% actually, through their own choice, reported telling us who they were. And most of the reports have come from GPs reporting things that have happened within their practice. So we've been speaking to lots of CCGs who have their own reporting systems, who've said one of the biggest struggles for them is to get general practice to report things that have happened within their practice. So we receive lots of reports about things that have happened within secondary care or elsewhere outside of the practice. But most of the local reports are to do with things that have happened elsewhere. But our data so far indicates that most of the reports are to do with things that have occurred in the practice. And as we expected, most of the reports are low harm, no harm incidents. But this provides us with lots of rich learning, because looking at the incidents, lots of them were prevented from becoming severe harms by systems and processes, but many of them were because of good fortune, so something caught them, and we can't rely on those, so this provides us with lots of good learning. Then we looked at what types of incidents have been reported, and the main ones were medication, by far. We looked at what stage of the medication process did the incident occur, and most of those occurred at the prescribing stage. Then we looked at what type of medication-related incidents were reported, and the other column, being really long, is a bit of a red herring. That's made up of all the other types of incidents. But the most common ones reported are the wrong drug, or an unclear or wrong strength or dose of a medication. Then we wanted to look at what drugs were mentioned most frequently in the very few reports that we've received to date. And the three top drugs out of 4 are anticoagulants and antiplatelets. So and I think historically these are areas that have been known to be high reporters, so these areas we've got lots of work to do. Warfarin seems to be top of the list, and it's a wide variation of types of incidents, from lack of or miscommunication at discharge to not acting on test results or the inappropriate doses of warfarin being prescribed. So this is just a snapshot of the reports that we've had to date. Okay, back over to Martin.
Thank you, Sabina. We're starting to eat the elephant. It's early days. It's only 1,000 reports, but we feel we're starting to unlock some of this problem that we've got. There's a massive cultural piece here that we need to work on. If we can persuade people that it's really important and that we need to know this stuff, it'll work. I think I was listening to Bill Kirkup last week, and this was his report from the Morecambe Bay inquiry into the failure of the maternity services there. I think it hits the nail on the head for me, really. This is, patients don't think we're perfect. I think lots of us for many years have thought we'll get away with it and we can just sit on it and be quiet about it. Patients don't expect us to be perfect. They expect us to make mistakes. But when we make mistakes, they expect us to find out why. When you look at the international evidence about people getting sued, actually what patients are seeking is not retribution. They're not seeking money. You can't make it better with money. What they want you to know and find out is they want to know what happened, they want to know why it happened, and they want to know what you're doing to make sure it doesn't happen to somebody else. That's all they want. When I have the privilege of meeting lots of parents. James Titcombe, whose son died in Morecambe Bay, the parents of Sam Morrish, whose son died of septicemia down in the West Country. They're actually taking this to a new level. Martin Bromley, who leads up the patient safety clinical human factors group, whose wife died. These people are amazing people who have the courage to actually just take it forward and say, well, what went wrong? Honestly, what went wrong? How do we make it better? And I feel somewhat ashamed sometimes that we don't say actually what went wrong, because we're afraid it's going to come back on us. And we need to get over that, because none of the patients I've met are actually there to get you. None of the doctors who've put their names forward on the NRLS have been struck off. No one's been reported to the GMC. Actually, it takes real courage to do that. We've got this new e-form, so think about how you can report how people can report, and just go onto that. It's a very simple link, so that icon's really useful. There's lots of stuff now about primary care patient safety on the NHS England website. And we're going to hear from Suzette Woodward shortly about Sign Up to Safety. Sign Up to Safety is a campaign, Secretary of State's campaign to actually say, what can we do to make things safer? There's so much patient safety activity now, patient safety collaboratives, Q Fellows, Q Initiative, that this is something that we will be expected to participate in. For those of you that aren't involved in primary care, I think there's a real opportunity coming with all the integration agenda. It's not us and them. It's not primary care versus secondary care. It's not secondary care versus community care versus, primary care. Actually, we need to work as a system around the patient. When you look around the world at where things work best, it's where people are working as a system together to make care better for patients.